INR is there's no role for plasma. There might be a role for vitamin K, there might be a role for holding a Coumadin dose, but if the patient's not bleeding, just don't do it. Just don't do it. All the time I see patients getting plasma transfusion to correct supertherapeutic INRs in the absence of bleeding. So treating the laboratory test and not the problem with the patient. And conversely, if the patient is bleeding, we're not going to quibble about what the INR is. If it's serious bleeding, you stop the warfarin, you give vitamin K, and then you do a rapid reversal with either protein complex concentrate, plasma, or something like 7A. Just wanted you to be aware of those. And there's also specific recommendations about handling that patient coming in for scheduled surgery. And they say, look, if it's routine and scheduled, what you don't do is see the patient 12 hours before the surgery and pop in 4 units of plasma to reverse the Coumadin. What you do is you see the patient days before the surgery, you stop the Coumadin, you let them come back to where they're not coagulopathic, and then you go to surgery. So again, sort of teasing out the use of plasma and substituting for it a better management of the patient in the perioperative period. And also notice that once the INR is 1.5 or less, they say go to surgery, the patient clots normally. We could spend another hour talking about use of plasma and interpretation of the INR, but suffice it to say, INR is a lot like platelet count. You all know a normal platelet count might be, what, 200 to 400? If a patient has a platelet count of 100,000, do you panic? Get them platelet transfusions, don't take them to surgery. What do you do when their count's 100,000? You don't do anything. You go get a cup of coffee, right? They can go to surgery. If their count was 150,000, which is still not normal, they can be a platelet donor. So you already know that in other things that you can be substantially below the reference range and still not be coagulopathic. Same thing's true of INRs. You can be substantially prolonged out of the reference range and the patient is not coagulopathic. And nicely, the chest surgeons anyway picked a value, gave everybody a value, which is 1.5 or less. If we got that far, it would be a good thing. I'd said this earlier, but just make the point again. If you adopt another hospital's guidelines, you own them. You have to defend them. And the fact that you may not have developed your in-house experts can't be an excuse for not having effective peer review. It's just too important to try to get the information out, get people pretty much doing the same thing and good things with their transfusion decisions. Okay, so I'm going to show you the guidelines from Dublin, Grant, and Riverside. What you'll see is while they are very similar, they are not identical. And that reflects the fact that there were different groups of people that developed them, looking at the same guidelines, looking at the same literature, and also then doing an adjustment for their medical staff, because at some point you need to be practical as well. Sometimes it's better to take half a step toward where you're getting and then revisit it a couple years later than it is to try to go right there the first time. And so I think all of those come into play in the way these had unfolded. But let's look at Riverside's. Had you adopted Riverside's guidelines? Okay, so you should be familiar with these then. Hemoglobin less than 7 or less than 8 in that prove it category. Okay, organ ischemia, hemodynamic instability, vascular disease, pulmonary insufficiency. This doesn't mean, chronic cough. Pre-op for a procedure that's going to have at least 1 liter blood loss or someone hemorrhaging. Platelets, less than 10,000 NOS. Less than 30 with prolonged PT, PTT, or fever where the platelets don't work very well, or platelet function defect, or where they're already showing you microvascular bleeding, which tells you that there's insufficient platelet activity. Less than 50,000 for most invasive procedures, and then part of a massive transfusion response, or a patient who's bleeding or going for urgent surgery and is on antiplatelet medication. I just learned this past week something that I've been waiting to hear, which is in patients on Plavix who have, of course, poisoned platelets, irreversibly poisoned platelets from the Plavix active metabolite. When they go for surgery and you give them a platelet transfusion, does that affect things like the bleeding time, the platelet works aggregation times, the PFA 100 closure times? And the answer is yes, it does. Those platelets are actually effective at partially reversing the platelet inhibition. We're giving a lot of platelets for that particular indication, so I was looking for the justification. It was knee-jerk. It was a best guess up until then. That was red cells, platelets, plasma. INR greater than 1.6 on Coumadin, or surgery or invasive procedure, or bleeding. So using 1.6 as the INR where you go from being, we know everything's okay, to you might be coagulopathic. Massive transfusion. TTP, or a specific coag factor deficiency. So pretty simple. And there's nothing new in cryo. Fibrinogen less than 50 or less than 100 with bleeding as part of a massive transfusion protocol, or in the rare patient with a documented dysfibrinogenemia. For implementing guidelines, couple of tips. It's important to get the guidelines in front of the physician making a decision to transfuse. If the physician doesn't see it, but the unit clerk that takes off the order does, or the nurse that gives the blood does, the intervention is wasted. The guidelines need to be in front of the physician making the decision to transfuse. And that can be because you've got a special order form, for example, that lists your guidelines. That's a very effective way to implement. If you have electronic physician order entry, you display your approved uses of the product with a write-in. And same thing, just putting them right in front of the physician at the time that they're looking. And then the second thing is, in support of peer review, be sure to require documentation of the rationale. If you're going to use a form and it's got your guidelines and they indicate which guideline applies, then they've documented the rationale. But if you don't have something like that, be looking for it in a note, looking for it on a standard order form. Some way you need to know what the thinking is about why that red cell was given at a hemoglobin of 8.8. Was it because the patient, it's outside of guidelines, but was it because the patient was particularly, I don't know, unstable hemodynamically or something? I mean, what was the thinking? And because you need that for the people that are going to do the peer review. And that must be my last slide. Yes?
I was wondering if any analysis was done as far as the age of the blood and the effects on the patient, or the immunosuppressive effects.
Sure.
Because I know a lot of things recently has suggested that the older blood has a much higher incidence of complications as opposed to 24 days of younger blood.
Right. The nice thing about that literature is, did everybody hear the question? The question is whether older blood is the culprit, and if we could keep everybody on fresh blood, will we not have these consequences of transfusion? The nice thing about that question and what's in the literature is it's still manageable. You can read everything that's been written about it, which I've done. And then I put them in piles, and I had like 8 articles that said that the age of the blood mattered, and then I had like 10 articles that said the age of the blood didn't matter, and then I had one that said if you get older blood, you do better. So that to me is, well, how would I read that? Not that there's not an effect, but that if there is an effect, it's relatively small. It might be limited to a particular patient group. You might have to be at the extremes, or it might involve cofactors. You might have to have certain cofactors at play in order to see the effect. It will shake out. Blood bankers are a little bit nervous about that because you can understand how it goes. If without good scientific support, somebody gloms onto demand that all the cardiac surgery cases, for example, get blood that's less than 14 days old, that means somebody else's patient doesn't get blood that's less than 14 days old.
But if that's
so you really need to know.
If that's not a factor, why would that be a problem?
Oh, because there's not unlimited inventory. So for each patient that you would protect from old blood, you've got a patient that you are resigning to old blood because you've got to use the inventory. So I'm going to wait for something to be definitive. I think this is an area where we can afford to be scientific, and we should insist on being scientific before jumping prematurely, into saying that there's a patient group that needs to be protected because of the implications for other patients and the availability of blood, that sort of thing. There's no question that as blood ages, it changes. Red cells that are old don't have 2,3-DPG. Now, they'll regenerate it after transfusion within hours, but they don't have it at the time of transfusion. What that does is it makes the hemoglobin a higher affinity hemoglobin than normal. It actually makes it look a lot like fetal hemoglobin, which is a higher affinity hemoglobin. So that means that when that cell gets to the capillary, it's less likely to give up the oxygen for the same difference in oxygen between what's in the blood and what's in the tissue. That's a real phenomenon. Up to 25% of the red cells won't survive in circulation more than 24 hours. In fact, that's the